Welcome back to the Ultraviolet Tide. It is officially November. I know it's not when we're recording this, but it is when this is going to go live. So we're going to pretend that it is November on our end, which means it is time for another episode of the Top 5 on the Tide. And as always, I have the wonderful Leah Adams joining me, but we also have a super special guest joining us. So Leah, I'm going to hand it over to you to give more insight into our wonderful guest today.
Absolutely. Well, we have a special guest in the studio today, and some of you may know her because she's pretty big on social media in the ocular melanoma community, Danet Peterson. And we're so excited to have her here today. And just a little bit about Danet before I hand it over to her to do a little bit more of an introduction for herself. She is the social media manager for A Cure in Sight, which is a nonprofit organization and trust source for all things ocular melanoma for patients and caregivers. She lives in Mesa, Arizona, with her husband, Danny, and their three adorable children, Joshua, Tatum, and Melody. And her role within A Cure in Sight is to help spread awareness for ocular melanoma, relate to patients, spread awareness across social media platforms, and truly give the patients population a voice. And Danet, we're just so excited you're here today. And beyond my introduction, I would love for you to tell the audience a little bit more about who you are and why you're here.
Yeah, awesome. Thank you so much for having me, Erica and Leah. And Leah, I'm so glad that we were able to connect. I don't even know. I think it was years ago, probably right when I was diagnosed on social media. Just a disclaimer, I do still help with managing and kind of running the social media behind the scenes, but I am no longer the official manager. That falls to my coworker Megan, who has taken that over for me so that I can have a little more time with my family and to focus on my own medical journey, as well as just to do what I do best, which is to be the host of the I Believe podcast. Megan and I co-host the I Believe podcast. So, in terms of what do, I was diagnosed over 4 years ago with ocular melanoma myself. And about 6 months into my diagnosis, I was approached on social media by the founder of A Cure in Sight, Melody Burchett, who is also a patient with ocular melanoma. And she asked if I would help just kind of make sure their social media could continue growing. And so I took that on, did that for a little while, and then eventually added in the podcast. And that is definitely where my passion lies, is in being able to connect patients with resources, and just like you said, allow them to have a voice and share their stories. So we now have the I Believe podcast with combined, I don't even know if I could count how many combined downloads we have now in the lifetime of our podcast, between our YouTube channel and the various different ways you can listen to the podcast. But if you search the I Believe podcast on a platform like, Podbean or Apple Podcast, then you'll be able to find us there. I believe we have, oh my gosh, my tech guy was telling me that we have well over 30,000 downloads just in the podcasting platform, probably is more. And then in YouTube, we have over 110,000 lifetime downloads. So we have a really, really rapidly growing platform that we are continuing to provide resources to ocular melanoma patients, their caregivers, and just really be a hub for that information, a long-lasting hub. And I am happy and proud to say that we are the number one source for ocular melanoma resources for patients to come to, aside from, of course, their doctors, right? But we do bring on a lot of medical doctors. We bring on researchers from pharma. We talk about clinical trials. We talk about a lot, in addition to providing patients with resources and just kind of avenues of help to just support their mental health and support their life as they're navigating a cancer diagnosis. So it's kind of just a good modge podge of lots of different resources. But where I live the most is I actually talk to a lot of the doctors. So from about 2022, I've been asked by some doctors if I have a medical degree, and I always tell them, yes, by osmosis. I have a medical degree of osmosis. I have absorbed the information that I take in from interviews and just in that capacity. So anyway, so I host the podcast, and I also help to host in-person events. So coming up this week, we actually have November 3rd, we have our live in-person Looking for a Cure 5K. And it's a 5K that is specifically for ocular melanoma. And that's happening in Scottsdale. It's actually the last opportunity people have to join that event and be part of the largest ocular melanoma focused race in the whole country for this year. So we're trying to beat California. We're trying to beat them. They had 350 people registered and show up, and we need to beat them. So currently we're at about 250. So we have 100 people to go in the next 4 days. So anyway, I help with those events, and I also help with our annual patient seminar, which is called the I Believe Seminar. And it's an opportunity for us to bring current research and medical news to patients, as well as provide them with lifestyle resources and just navigating their diagnosis, mental health supports. We had like a hypnotherapist, we've had a music therapist come, like just kind of helping them see that there are ways to cope and that we want them to cope and to thrive, really. It's not just survive with this diagnosis, it's learn to thrive.
That's awesome background. And I'm excited to have kind of your insight as we dive into our stories for November. I think your take on things and your perspective, especially when we talk about some of these drugs and things that Leah and I are like, this treatment goes right over our head. We're excited to have your take and insight into it so that we can, deliver the best, most up-to-date information we can for our listeners. But thank you for that introduction. And without further ado, let's dive into our 4 stories for November. So the first story we pulled is from People, and it is about Katie Couric. So the title is Katie Couric encourages eye health checkups after friend is diagnosed with rare cancer. So Katie Couric, who I feel like we all know, she is a cancer survivor herself, an advocate. And in this article, she revealed that her friend was diagnosed with uveal melanoma, which is a rare eye cancer. So uveal melanoma, also known as ocular melanoma, is a rare type of cancer that occurs in the tissues of the eye. Symptoms include blurred vision, floaters, flashes of light, a dark spot on the iris, changes in pupil size or shape, and changes in the position of the eye in the socket. She continues to write, uveal melanoma is a very rare eye cancer that affects only 3,000 people in the United States every year, mostly fair-skinned people with light eyes. I should have given a disclaimer. This is from a social media post that they pulled, so these are directly her words. She continues, that's why it's so important to get your eyes checked every year by an ophthalmologist, people. She continues, Shiri is part of a clinical trial. Another reason it's so important to support cancer research. She is in the hospital now. Please send lots of love and healing thoughts. I love her, and this will make her day. Thank you, XO. So, Danet, I'm going to turn it over to you first to share your thoughts on the story, especially when it comes to some of those symptoms that people might want to look out for.
Thank you, Erica. So I'm going to just totally own that I kind of tend to avoid social media sometimes myself. And so I haven't actually seen this story. If you want to send it to me, I'd love to reshare it and make sure that we can feature it on Ocular Insight's Facebook and, their feeds. But in terms of what she talked about as far as symptoms, one of the most important things that we like to drill home at Ocular Insight when we are talking about getting your eyes dilated, right? And we've talked a little about this before the call that like November is the I Get Dilated month. And that's previously been established, I think, by the CureOM Foundation with MRF. And we just kind of all hop on that bandwagon that we encourage people to get their eyes dilated. We talk about eye exam month in August. We talk about melanoma awareness in May. We really try to drive this point of getting your eyes checked home like every single month in some capacity. That is our main goal, which I'm sure you guys can relate to because skin checks are not just for one time of the year. They are every single month. And breast exam checks, like they are not just for one time of the year when you go get your annual mammogram or you go to your OB for an annual wellness check. They are for every single month that you check in regularly. It is not just it is not just a once in a blue moon kind of a thing. So eye exams are one of those things that we've done a lot of work in spreading awareness with doctors and just having doctors give their opinion. So for example, Dr. Murthy Njaya went live with us in August and talked about how important it is to have an eye exam and what consists of a good eye exam. So let me just kind of run through those with you. So the first thing is that, yes, it is important to get your eyes checked every year if you have the ability to do so. If you don't have the ability to do it every year due to insurance coverage or just whatever the kind of holdup might be, for the majority of patients, I think under the age of 40, maybe 45, once every 2 years is considered medically adequate unless you have something already existing in your eye. So what is that? You might have been told that you have something called a nevus. Think of this as like a freckle on your eyeball or a freckle on the inside layer. Sometimes they are on the outside where you can actually see it on the white of the eye or on the iris of the eye. But for the most part, these nevi are something that are visible on the inside. And similar to skin cancer, these kinds of little nevi, these little moles in the eye, so to speak, are not commonly the ones that turn into cancer. They can, but they're not usually like, it's not usually that that's the reason that you have a benign nevi that then turns into cancer. So that's just something that, can be kind of misunderstood, is that, oh, you must have had a freckle in your eye. It's like, well, yes, it could have developed over time, but the bottom line is it's not, every nevi is not an ocular melanoma. So that's the first thing. If you do have a nevus, however, you've been told you have a small spot on the inside of your eye, it is imperative that you go every single year to have it monitored. Because if it does change, the faster and the quicker that they catch that change, the easier the treatment is, and the more likely that you as a patient will have a long-term survivability, so that you will be okay, basically. So in my case, symptom-wise, like you talked about some of these symptoms, right? You talked about blurred vision. You talked about the shape and change of the eyeball, like the direction the eyeball faces. Like really, the general rule of thumb here is that if you have visual changes in one eye, you should always go get them checked. And you should always start with going to a medical ophthalmologist if at all possible. Not a bad thing to see an optometrist. My optometrist is the one who started the journey for me of getting diagnosed. As long as they have the ability to do that full-scale evaluation. A full dilated eye exam means that they put drops in your eyes. It means that they're looking inside with the scope as a personal doctor. They're using their eyes to look inside your eyes. And they're using the dilation to widen the field of vision. If you only look through the pupil and it's not dilated, your ability to look through the eye is limited to about like a very narrow pinprick of light. So dilating the eye actually widens that field of vision. And unfortunately, it doesn't widen it to cover the entire inside of the eye, right? It's impossible to put a mirror inside the eye and bounce it back and look at the very front of the eye in every instance. However, that's where the imaging comes in. So if you're offered the opportunity at an eye exam to have a retina scan where they take pictures of the inside of your eye, they do what's called wide field retina imaging. And that wide field retina imaging is something that we also really heavily encourage our patients to tell their friends and family, go get your eyes checked and have the pictures taken. Because what does that do? Well, just like with a skin check, it actually creates a record. So if you do have something on your eye, they can track it and they can see over time, yes, it's changing, or no, it's not, and they can prove it in a photo versus just somebody eyeballing it and writing notes and saying, no, I don't think it's changed versus the last time that they saw it, so it leaves less guesswork. It's just kind of another way to cross-examine or just kind of cross-check your work, so to speak. Always best to get the dilated eye exam with the drops. I know some people hate getting the dilated eye exam, and some ophthalmologists and some optometrists will actually tell you you don't need your eyes dilated to have the photos taken. It's not true. Your field of vision that they can get a picture of is still limited. If you have a non-dilated eye, they can't get the most adequate and the most wide field picture inside your eye because your pupil is no longer dilated to allow for that field of vision. So it is always better to have both exams, the dilated exam with the doctor with the drops, and to then follow it up with the wide field retina imaging. The kicker, and this is what we talk about a lot at Ocular Insight, is that it's not just to go in for symptoms. Like, you should not just get your eyes checked if you have symptoms. You should be getting your eyes checked every year, because I cannot tell you how many patients I have run into in the history of all of the patients I've met over the last 4 years since I started my work with Ocular Insight, who were found, like they were diagnosed because they went to a routine eye exam for glasses, they needed a prescription change, had 0 symptoms, and they walked away with a cancer diagnosis. And it's mind-boggling. And obviously it's not something that we want for anyone, right? We never want to walk away with a cancer diagnosis. But the bottom line is that if you talk to any of the top ophthalmologists, the top ocular oncologists in the field of uveal melanoma, they will tell you that early detection of this cancer is the most likely scenario to provide long-term survivability and make sure that patients are actually okay, and that they never actually develop metastatic disease where it goes from you have cancer in your eye to 4 years later you now have cancer in your liver and in your lungs and you're being told you have a stage 4 diagnosis.
Right.
That's where I live, and I had a massive tumor that just basically kind of exploded in my eye in terms of the ways that the tumor can manifest on imaging, and I didn't have a chance to get it detected early because it was in a really bad location and it was just bad luck, I guess. Mm-hmm. However, people who do have those routine eye exams have the best shot that if you are going to have any kind of health condition, including ocular melanoma, found because of an eye exam, it's going to be found because you go in every year. Yeah. And there's actually a lot of things that you can find out. You can learn about a stroke in the eye. You can learn about if you have diabetes. Like if you have diabetes developing, like if you're developing type 1 or type 2 diabetes, you can see it in the eyes. And so an eye appointment every year is just another way that you can get your general whole body health taken care of. So hopefully that is helpful, and I just will get
Yeah.
off my high horse for a minute.
No, it's great. I was about to say I am learning so much already. And Leah, I know you're going to have a lot to say about the clinical trial piece of this story because you talk a lot about clinical trials and are super passionate about it. So do you want to hop in and share your perspective from that angle?
Sure, yeah. I mean, I am a firm believer that if people don't volunteer or support research, like volunteer with or support research, we're never going to get close to finding a cure for any cancer. And so I know how important it is to support research and fund it. And if you feel comfortable participating in trials or research studies, just try it. I mean, clinical trials and clinical research sometimes can have a really negative stigma to a lot of people and even certain groups of people. But I think it's more going back to how we are informing people and educating people about the purpose of clinical trials and clinical research. So yeah, I mean, I am all for it. And especially just like Danet sharing all of the knowledge and insight that she's sharing. I mean, when I was diagnosed with melanoma, when I was told that I had to go to the eye doctor now for sure once a year, I was so confused. I was like, why? I had melanoma on my chest. Like, why do I need to go to the eye doctor? And then I got the spiel about how melanoma can happen in your eyes. It can happen in your mouth. It can happen in your lady parts. It can all the things. And so they were
Like
very,
all the
very
things you never wanted to know.
exactly. So, but you know what? The more that I know and the better that I'm now taking care of my body after melanoma. And one of the things that I have really dove into is supporting research and getting involved in clinical research, along with my dad, who's also a stage 4 metastatic melanoma warrior. So our family loves research. We support it. And we know that if more people don't get involved, we're not going to get close to a cure one day. And that's what we all want ultimately.
Well, and just to add to that, I would say joining clinical trials isn't for everyone, right? Sometimes there are things happening in your treatment journey that necessitate not being part of a clinical trial. However, one of the things that I talk about at a Cure Insight, and I actually interview people from pharmaceutical companies who have current clinical trials in uveal melanoma to talk about, how does the trial work? How does the science behind it work? And also, what are some of the eligibility requirements for patients? What are the travel kind of reimbursement options? How accessible can this be to people? One of the things that we always talk about is how a huge misconception, I think, around clinical trials is this idea that if you sign the contract to be part of the trial, that you're like signing your life away and that you can't back out. The bottom line is you as the patient can back out and you can change your mind at any point. Whether or not you want to continue trial A, B, or C is all up to you. And you have power over that. And I think that that is such an empowering thing for patients to be able to know going into it. If they have the opportunity to participate in a trial that is the right fit for them, that is the right kind of treatment for where they're at in their journey, like it is so vital to understand that they are in control. And that no one from those pharmaceutical companies is going to railroad them into, and then any clinical investigator, so the doctors who are hosting the trials, they should not be in any way trying to sway you to participate in a trial you are not comfortable continuing. So, and like to that effect, like I wish I could say that I've already been in a clinical trial, and I guess technically I've been in one. I've been in an adjuvant or a pre-metastatic treatment, like an attempt to prevent metastatic disease from happening. Because the kind of funny, crazy thing about how eye cancer works is that, yes, the eye needs treated, but the primary eye tumor is not actually the reason of mortality rates in uveal melanoma. And that's kind of the most mind-boggling thing to some people is like this idea that, oh, well, it was in your eye, so how did it get to your liver? And most people who do pass away from this cancer are actually dying because of liver failure, because their liver can't sustain the amount of cancer that has grown in their liver, or because they've participated in various different treatments and the toxicity to the liver is too high, and therefore the liver shuts down, which both things are not ideal. We don't like either of those. But that's kind of the most mind-boggling thing about this is that you can have a diagnosis like me. I was diagnosed in July of 2020 with ocular melanoma, had a massive tumor, prognosis from my Castle Biosciences test came back and said, you've got a pretty high chance that this is going to metastasize within 2 to 5 years of your initial diagnosis. Like, we can't say for sure, but here's the percentage that we know based on the genetics of your tumor. This is what we know. This is what we believe is possible. And so then I began this journey of like every 3 months, I was having scans. That was when I entered a clinical trial to do an adjuvant trial in Philadelphia and just try to make a solid attempt at taking medicine that could give my body a fighting chance to basically go after these little micro metastases that live out in my bloodstream. And the way that I describe it is it's kind of like they're just floating around until one day they decide to set up camp. And they set up camp in your liver is the most likely place for them to set up camp. And if they decide to set up camp, it's really hard to kick them out. Like it's really hard to kick out this little expanding family of little melanoma pieces that are trying to grow in your liver. And that once they have a house in the liver and they set up camp and they have neighbors and they have family that grows, like they've got children and they've got aunts and uncles and grandparents, like once they have an established place in your liver, it is very, very difficult to kick them out. And to date, we do not have anything curative. We don't have anything that does more than prolong life in treatments. And we thankfully do have a couple of FDA-approved treatments that have come as a result of clinical trials. And but I will tell you that those clinical trials have been over 10 years in the development of that drug or of that method of treatment. And it's only now in the last, I think 2021 was the first year that we got Kimtrack, which is the first approved drug. And it only works for some people. It only works for certain blood types. It doesn't work. And even in the certain blood types, it's not a guarantee that it's going to work forever. It may work for 3 months, may work for 3 years. You don't know. So the uncertainty that patients deal with in this diagnosis is insane sometimes. Actually, most times. It's not even a sometimes.
Yeah, no, for sure. And speaking of treatments, specifically FDA approved procedures and drugs for ocular melanoma, our next article is actually talking about something really unique. And this source is, or the article is from the source UCLA, and the article is titled "Novel Procedure Helps Treat Renowned Chef's Rare Eye Cancer." And this chef's name is Sunny Sweetman, who Danet informed us is Oprah's chef. Of all people, and was diagnosed with rare uveal melanoma in 2022, which, as we learned, is a rare type of cancer that occurs in the eye. The melanoma is derived from the melanocytes in the uvea, accounting for only about 5% of all cases of melanoma in the United States. Only about 1,700 people are diagnosed with this type of cancer each year, according to the National Cancer Institute. So essentially what happened to this chef is after initial radiation treatment, his cancer spread to his liver. As Danet was just talking about, standard chemotherapy was ineffective for long-term control. So UCLA introduced to him this new Hepzato kit, which is a new FDA-approved procedure. And essentially how this is different from chemotherapy is that the Hepzato kit directs high-dose chemo to the liver, sparing the rest of the body. So this minimally invasive procedure involves an extracorporeal pump to filter chemotherapy. And with UCLA's highly trained team, performed the procedure twice on the chef. And something to note about this procedure and this type of therapy is that patients can receive this up to 6 times. And Sweetman, the chef, had the procedure twice. And on both occasions, he was discharged from the hospital the next day and returned to work within a week, which is crazy that he was able to bounce back, that quickly. So the introduction of the Hepzato kit represents a cutting edge and promising development in addressing this challenging condition. And this was said by the director of the non-operating room anesthesia for UCLA Health. And ultimately, the goal is to extend survival, as Danet pointed out previously, significantly, with some patients now surpassing 2 years post-treatment. And I think, to me, I'd love to hear your guys' opinions on it, but when I read this story, I just felt hope. I felt hope as far as, more treatment options for people. The fact that, this individual, I know everybody's different, every patient is different, but the fact that he was able to bounce back so quickly after treatment back to work, that is amazing. I mean, when I talk to people that have had, metastatic melanoma, sometimes they have to stop working for a long period of time because the side effects are just so severe on their body. And I know my dad was one of them. He had to early retire because his body just couldn't handle life after doing 21 rounds of immunotherapy and 7 rounds of brain radiation. So, Erica, I'll pass it to you first this time to hear your thoughts on this. Did you hear about this story? And then maybe Danet can piggyback off of you.
Yeah, I think this was such a good story to bring up, especially because Danae was just talking about the treatments and liver and like how everything plays in. And I will not even try to pronounce half the words that were in this article. So well done, Leah, going through those. But I think my first thought as I'm just kind of reading through this is I know, Danae, you were just saying how the treatments that are out there only work for a certain percentage of the population. So I'm curious your thoughts on this exact treatment and how it works specifically, and if from your experience and what you've read and seen as you talk to doctors and through those conversations, is this working? Is this a treatment that, we can get really excited about, or is it still only affecting a certain percentage of the population in terms of its effectiveness?
Okay, so first off, I want to just say that, I will send you the links for a couple of the interviews that I've done with 2 doctors out of UCLA who actually are the first doctors in the country to, outside of Florida, which is where the majority of the clinical trials took place. They are the first doctors in the country to have the most functional treating site for Hepzato kit. So they've been treating patients the longest since approval of the FDA approval. And so I do have an interview with Dr. Chymlowski from UCLA, who's a medical oncologist there who treats uveal melanoma patients. And I also have an interview talking about how does this treatment work with Dr. Padia. So if you want to know a little more about how it works, you can definitely go listen to them. One of the most important things to realize is that the data around this that I have talked to the Delcath representatives, who they're the company that manufactured this technology and they developed the clinical trial. They are the reason it is where it is. And the data around this is insane. Like, it's insanely good. They have, and I don't want to quote statistics because I'm going to remember the wrong numbers, but they have a very high percentage of response rate, meaning they're seeing tumors shrink. And on top of that, they also have a very good overall survivability. So the efficacy, or the way, like how well it works, this is the highest that we have in terms of any known treatment. And this is the only high efficacy FDA approved medical procedure that we have to treat liver metastases. The problem is that this does not work if you have extra hepatic metastases, meaning if you have something in your lungs, this doesn't treat that. It will not affect those. You can have things in your liver, you can have things in your lungs, you can have mets in your bones. And while they can treat the liver, this medication, this methodology of how they're administering the medication will not affect in any way the whole body. So it does not systemically treat cancer. So if you do have things outside of just the liver, which is not, it's not uncommon to have that happen. Once it's in the liver, it's kind of like it has a free railroad to go everywhere else. It doesn't always go there very quickly. For some patients, it takes a while. But for those who do end up having things, show up in their liver, their lungs, somewhere else outside of the liver, this treatment doesn't treat anything aside from the liver. So that's the main limitation to it. The other thing to keep in mind is that, and I don't want to make it sound like this isn't a good option. Like, it was absolutely one of the best options for our just known data and just known liver-directed therapies. But the main caveat is it can only treat liver metastases with uveal melanoma patients. There's also some caveats to at what point can you have this treatment. There's a point that if you have too much tumor burden in your liver and you have too much actually like kind of populating your liver, this treatment won't be effective because it will be too hard for your liver to handle. So there's a lot of different blood work and there's a lot of tests that they do ahead of time to make sure that you are medically eligible for this procedure, that you can withstand anesthesia because you do have to be put to sleep. And so there are some kind of qualifying factors. And like I said, and I did interview Dr. Padia and Dr. Chymlowski. They're on our YouTube channel, and there's some really awesome interviews with these doctors just talking about, who's eligible for this. So I'm going to defer to that. I'm not going to go into that because we could go on for hours about that. But the other kind of unique thing about this is because it is an FDA approved treatment, doctors now they have room to work with this. They have room to work with this and say, okay, well, we have this option. And now can we combine it with another therapy, right? Can we take a liver directed therapy and combine it with a systemic therapy that is already approved and that we know that we can use in uveal melanoma. It's not super effective in uveal melanoma in liver metastases, but now that we can tackle the liver with Hepzato kit, can we tackle things in the rest of the body somewhere else with like we have some patients who respond really, really well. Not very many, but we do have some patients who respond really, really well to Ipi-Nivo. Those patients are usually most responsive if they have metastatic disease in the liver, or sorry, in the lungs, in the bones, in the breast tissue. So patients who have something outside of the liver have a little bit better of a chance for that to potentially work. So we now have room for that research to happen, right? We have a Hepzato kit approval for FDA approval. And because of that FDA approval, doctors can now pursue research in these other areas. And they can now work with patients on combining therapies and just really getting more creative. And that's something that both of these doctors talk about in my interviews with them, is that they talk about how much hope it gives them as providers and how much hope it allows them to give their patients. In addition to just the data and the efficacy and just how well this drug does work. Like we said, it's not curative. We wish it would be curative, but for some patients, it really does provide long-term survivability. And that long-term survivability means that you have more opportunities for new trials to come out that could be a little bit more helpful, or for new research to emerge that shows that a combination of A and B and C is going to be the most helpful for your cancer type. It just gives you time. And in our disease, that's what we talk about all the time with uveal melanoma. We want more time. Obviously, we just want more time, like period. But the time also translates to time for clinical trials to take off, time for research to advance, and time for treatments to get approved through the FDA.
Wow. That was really informative to know. You are essentially a physician in my eyes.
My mom is like, you need to go to medical school. I'm like, Mom, when? When would I go to medical school?
Oh my gosh. No, I'm like trying to soak up all of this information like a sponge. It took me years to figure out melanoma and like all the terminology surrounding it and all the treatments surrounding it. And I remember I went to like my first conference, and it was embarrassingly the first time I just had absolutely no idea that any of these other forms existed. And I was so embarrassed to like, I was sitting there and I was like, okay, I need to soak up all this information as much as possible. And that's how I feel right now. Again, it's like, okay, well, now I know these types exist, but it's like its own ecosystem in and of itself.
Well, and I think, it's fair. Like I think that it's fair for us to recognize as patients, especially as patients who are going through this ourselves, right? Like it sounds, if I'm understanding this correctly, are we all melanoma patients of some kind?
So
Eric is not.
no,
Erica's
I'm
not.
not. My mom. Yeah, my mom
Your mom
was.
is. So you have some connection to it. So like Leah and I are actual patients. You have a direct line connection to a familial, a family member. And I'm just going to put on my, not a psychotherapist, not a therapist, but also this is trauma. Like this diagnosis is family trauma. It is trauma to the patient. It is trauma to the family. And there is no way and no world where I think anyone expects that any patient of one person going through, or, any patient with one type of diagnosis, right? That's what we're dealing with, usually one type at one time. Nobody has the bandwidth to absorb all of the information about everything all of the time. And so there's really nothing wrong. Like I hope you don't feel ashamed that you didn't know, because you were dealing with something very traumatic in your family. And I think we all have tunnel vision. We get tunnel vision on our diagnosis. And that's not a bad thing, because it allows us to really navigate it and to learn everything about it that we can, if we are that kind of person, and therefore to get the kind of treatment that we need and to have the resources we need. It's so important that we have the ability to kind of disassociate and distance ourselves from the wider community that, like you said, it's like this huge expanding branch that you're like, you didn't even know it existed, with the caveat that we can still have space and have room to talk about the fact that, well, yes, there is cutaneous melanoma, and here's the statistics, the statistics on that. But also, did you know you can get melanoma in your eyes, and that it's not going to hurt us as communities to support each other and to support awareness around these different rare types and rare subtypes of cancer? Because at the end of the day, we can't do it alone. And the rare people are the ones who usually get the short end of the stick, because we're the ones who, if there is research happening, money doesn't go to us first. Money goes to where research money goes to where it is most lucrative, and it's most lucrative in a larger patient population. When you only have 1,700 people in the US who are diagnosed each year, and maybe roughly, I think the new statistic now is that we expect roughly 40 to 50% of those patients will develop metastatic disease at some point in their life. So cut that number in half. each year. Maybe they're not diagnosed that year, but just of those people diagnosed, 1,700 divided by 2, I think that's about 850-ish. That's about 850 patients in the United States alone. That doesn't even go into the rest of the world. Worldwide, there's maybe a total of 7,000 people diagnosed with this per year. And half of those people, roughly, will go on to develop metastatic disease and be in need of clinical trials, treatments. And so, again, not a very lucrative place, right? And so the companies that we do have are usually smaller companies who are going into clinical trials and research development. And they're doing everything they can, and they're very passionate. But at the end of the day, they don't have a lot to work with. They don't have a lot of patients to work with to get to approval. And there's numbers, like I'm sure you know this, Leah, like there's numbers that require a clinical trial has certain parameters. They have to meet a certain patient number count in order to get to the next phase or in order to get to the next level of drug approval. They can't even submit to the FDA until they have met their quota. And if they need 100 patients on a trial and they're only able to take a certain demographic, there's all kinds of eligibility requirements. It just makes that process that much harder and slower. And so in the case of like Hepzato Kit, while we're so excited and grateful that we have it, the reality is that it took over 10 years to get there. Like over 10 years. And in that 10 years, most of the people who were diagnosed with metastatic disease, I can't put a number on it, but I would say more than 90% have now died because they did not have treatment that worked to prolong life.
Gosh.
And so like, that's just kind of one of the harsh realities is that even though we do have research happening, it just isn't fast enough for the people today. And we have a lot of things that are moving forward more quickly because of the FDA approval. And that's something that I don't know if you guys have seen this in your like history with melanoma, but in our, like in my history, I went from, I got a class 2 diagnosis, highest risk prognosis, being told there really were no options for me if I did develop metastatic disease, to now I don't have a lot of clinical trial options. And that's due to some kind of personal reasons in my own circumstances. But there's, I think, anywhere from 15 to 20 different clinical trials out there for metastatic disease, with more in the works or kind of oscillating between which ones have sites open, where are they located, all of that. And the unique thing about FDA approval is that when you have FDA approval of, say, Kimtrack, which was our first FDA approved immunotherapy that we have for uveal melanoma patients, and then you also get Hepzato Kit quickly on the tail of that, then we now have the attention, right? We have the attention of the media. We have the attention of kind of the general pharmaceutical community. And so now we have people who are more willing to invest because there's proof that they can go somewhere with it. And that's an important thing for all of these kind of developing clinical trials that haven't even made it to taking patients yet, or to the ones that are in phase 2 or phase 3 and they're fast tracked for approval now because they have grounds to say, we believe we can be the next FDA approved treatment. Help us do that. Help us make sure these patients have access to our treatment. Here's the data we have to support it. Like, there is a lot more happening a lot more rapidly in uveal melanoma as of the last couple of years because of the FDA approvals. Not necessarily that the FDA approvals themselves are, providing some kind of life-changing solution. It's that they're really paving the way.
That's super interesting. Again, I'm just listening to all of this, and I agree with what you first said about each of these cancer subtypes. They really shouldn't operate independently. I mean, we're all kind of playing the same game when it comes to dollars and where they go. And I think there's just so much that can be done, like even before you get to the clinical trials. I'm more so thinking of like how much education, even on like social media, is just lacking that you don't see. Like, I've never seen statistics of ocular melanoma really shared broadly or stories shared broadly. And we've seen this with the melanoma movement, is like people were so hesitant to talk about it.
Yeah. No, it definitely is. That is a factor. Like, I will own, and I tell people all the time, like, most patients are not like me. They are not the ones who are heavily involved in advocacy, who are heavily involved in putting information out there and making sure they're not the ones who are absorbing everything like a sponge. There are some people who do that on a personal level, but to do it both for yourself and to also do it on behalf of a community of people is a completely different kind of a thing. And it's something that not everyone has the bandwidth for. And I am one person. I am one person with a team of a few other people who help me kind of accomplish the same general goal. But at the end of the day, I am one person with a team of maybe 3.
Yeah, right. I think our next story is a great way to tie in if people are listening and they're cancer survivors, they're melanoma survivors, and they hear us say all the time to protect the skin that you're in, to go get skin checks, to wear sun protective apparel. And they're probably like, oh, yeah, well, I always wear sunglasses. And I think this story does a really good job explaining the importance of sunglasses, particularly ones that actually protect your eyes. There are a lot of trends going around right now with the super skinny, trendy, like sunglasses that don't really provide a lot of protection for your eyes. So, the next story is the importance of sunglasses more than just a fashion statement from the Nevada Cancer Coalition. So, the story starts off by sunglasses have long been associated with style, but their importance goes far beyond mere fashion, as we all know. While most people are aware of the need to protect their skin with sunscreen, many overlook the importance of shielding their eyes and the surrounding area. So, the skin around the eyes is some of the thinnest and most delicate on the body, making it particularly susceptible to UV damage. And I know a lot of the women, particularly who are listening to this, know that their eyes are the thinnest area because that's why we apply our eye cream very liberally. So, I know we know this information, so let's apply it to sunglasses as well. It continues, wearing sunglasses isn't just about preventing skin cancer, it's also crucial for maintaining overall eye health. So, UV exposure has been linked to several serious eye conditions. So, cataracts, which we all know about, macular degeneration, and keratitis are three of kind of those big ones that UV exposure to your eyes, if you're out in the summertime. I know I have blue eyes and I am so sensitive to the sun. I physically cannot go outside without wearing sunglasses. And I don't know if that's something that, if those who have brown eyes or green eyes feel the same, but I can't drive without my sunglasses. I can't walk outside without them.
Good point. I mean, I have blue eyes as well, and I fit the demographic as far as fair skinned, blue eyed for the ocular melanoma demographic. I fit the coloring as far as the, skin tone and the eye coloring. However, in terms of just random facts, I don't fit the rest of the demographic. The rest of the demographic says that most patients diagnosed with ocular melanoma are actually white Caucasian males over the age of 50.
Interesting.
Yeah, I'm really one of I was diagnosed at 28, and so I don't really fit the mold. But in terms of sunglasses, that's something that we talk about a lot too. It's one of those tricky things that because of, lack of research and just how rare this cancer is, we don't have a way to definitively say, yes, this type of ocular melanoma or this specific genetic pattern in ocular melanoma is linked to UV damage from the sun. However, like you said, there are other skin conditions or other eye conditions. The skin around the eyes is a very sensitive area, and it's not going to hurt anything to protect your eyes in that way.
Mhm.
Whether it's that you're protecting your eyes from just literal intense sunlight and just the kind of the damage that can happen there, because it is possible to, to have your retina kind of sunburned, so to speak. And so it's possible for the insides of the eye to be damaged because of light exposure. I will say we do have some very definitive research from Dr. Shields, who is at Philadelphia Wills Eye Hospital. And I don't remember if I talked to her about this in my interview with her, but I did an interview with her this year where she, I believe, alluded to some of the research that says that we do know that welding is linked. Like the non-protected, like if you're a welder and you do constructive welding, that if you use welding equipment without proper eye protection, so without the type of safety goggles that include that UV filter and include the ability to protect your eyes from the wavelengths of everything happening in a welding environment, then you are at a higher risk for developing ocular melanoma due to
Wow.
the damage that can happen to your eye from that type of radiation or UV or just whatever it is.
Mhm.
I don't actually know what goes into welding, but I just know that welding has been definitively linked to ocular melanoma. So
Interesting.
if you're a welder, please wear your eye
Yeah.
protective wear. But at the end of the day, wearing your protective eyewear is so important for a number of reasons. And some of them you alluded to in the article, and I agree with those. I will just kind of add in there just because I am someone who practices holistic health. And so I do a lot with an integrative oncologist to manage my own cancer journey. And some of the things that I have come across have talked about the importance of natural sunlight and how important that is to our circadian rhythm. And so like there's a lot of kind of schools of thought around the idea that yeah, we need sunlight, but like how much and what's a
Mhm.
healthy amount and all of those things. And sunlight is something that is absolutely vital to our bodies being able to have a natural circadian rhythm and to support healthy sleep, to support our immune system. So we do need sunlight, and we need non-filtered sunlight where we actually get just the direct, exposure of being outside. So do your research, like learn about healthy times of the day when it's actually safe and the UV exposure is low enough that you can benefit from the natural light, but not compromise the potential of hurting the skin around your eyes or hurting
Right.
the internal pieces of your eyes, because there's so many layers and the eyes are really such a sensitive organ that it is important to
Mhm.
protect them.
Yeah, absolutely. I love the point that it's not just sunglasses, it's also other protective eye gear.
Yeah. Just to kind of throw it out there, like I have one working eye. And so I need glasses to see, but I also wear glasses to protect my living eye because I only have one eye that works now. And so if I am in a dust storm or in a car accident or just somebody flicks something my way and it happens to collide with my face, my kid elbows me, like I need something to protect this
Yeah.
layer here. And so having polycarbonate lenses that are shatterproof and more likely to protect my eyes, from something coming at me is imperative because I don't have another eye to work with. I only have one left.
Mhm. Yeah, I think that's all great points. And Leah, I was going to hand over to you for the last story because we're going to talk about a topic that we talk about a lot on here, and that's insurance and gaps to um, treatment. So, Leah, do you want to take us into our final story for today?
Yeah, absolutely. And just a disclaimer that even though what I'm going to talk about in this article is a little heartbreaking and really sad, I think it also sheds light on advocacy and how we still need to do a lot of work to advocate for, only all cancer patients, but specifically like rare cancer patients, I think need a lot more advocating for. And that being said, the article that I'm going to talk about to end the episode is from a source called Helio. And the article says patients with Medicaid and no insurance may face barriers in access to uveal melanoma care. And so really kind of how I broke this article down was in a couple of talking points here. So the first one was talking about really limited access to preferred treatment. So patients with Medicaid or no insurance are less likely to receive, Danae, is it brachytherapy?
Brachytherapy.
Brachytherapy. Thank you, Danae, our professional, which is the preferred treatment for uveal melanoma and more likely to undergo removal of the eye through surgery due to access limitations at specialized centers. Another thing the article talks about is increased disease stage at diagnosis. So again, looking at uninsured and Medicaid patients tend to be diagnosed in later stages with a higher likelihood of advanced tumors at diagnosis compared to those with private insurance. Again, Danae kind of was touching on this earlier in our episode. Another topic in the article talked about socioeconomic challenges. So factors like poverty, lack of insurance, rural residents contribute also to delayed diagnosis and limited access to effective treatments. It also touched on implications of survival rates. Although Medicaid coverage does not directly impact survival, patients with Medicaid or no insurance often face treatment disparities that could affect outcomes due to more invasive surgeries over less accessible therapies like radiation. So what is this all saying? So this article is essentially saying that there needs to be better policy recommendations and things being done, and researchers emphasize the need for policies to improve access to regular eye care, as Danae was talking about, which could enable earlier detection and intervention for uveal melanoma in underserved populations and really addressing socioeconomic inequities. So the findings underscore the necessity of addressing structural barriers within the healthcare system to provide equitable cancer care access to all. And so even though, again, a lot of that was really like sad and heartbreaking to hear, it's reality. And I think it's really important to emphasize that, not even just with rare eye cancer, there are a lot of health disparities happening in a lot of disease states and illnesses and cancers across the country and across the world. And a lot of these barriers and health disparities could be stopped. But it ultimately goes back to, policies and our environments and how things are structured and laws and bills and all this kind of stuff that, I have gone to Capitol Hill in Washington, D.C. to testify, and, try to advocate for patients. And it just is a reminder that we still have a lot of work to be done. And Danet, I don't know what your thoughts are on this article. I'm sure you have a lot.
So there's a lot of points that you touched on here that are absolutely big issues in our uveal melanoma community that we recognize and that we really seek to help patients navigate. And one of those is the ease of access to care. When you're a rare cancer patient and you're diagnosed with a cancer that, roughly 1,700, maybe let's just round it up to 2,000 people in the United States might be diagnosed with this per year. If you're diagnosed in a rural area, chances are your doctor's never seen this before. If they have, you're lucky. And if they haven't, then they're going to have to send you somewhere else. And the reality of going somewhere else means that you could be traveling hours to states away. And so the majority of our patients who are diagnosed are coming from out of state. They're going from, say, Florida all the way over to Texas, and they're seeing someone in Texas instead. I lucked out. I live in Arizona, and I happen to be in a place where there are actually 2 to 3 treating physicians who are ocular oncologists or retina specialists who specialize in treating ocular melanoma. And so for my initial primary tumor, like when my eye was diagnosed, I didn't have to travel very far. I got a 45-minute drive to go to treatment. However, because it's so rare, the insurance battle is always so fun. And so you run up against the idea that okay, well, are they going to actually take this? Are they going to take this and say, yeah, sure, we'll cover this? Or is there going to be no, we don't see how that's necessary. Do this instead. I will say that at least in the patients that I talk to, I don't hear of enucleation happening super often due to radiation being denied. I don't think that it doesn't happen. I think that it probably does still happen, but it is not something that we hear about heavily in our community. Or at least not something I personally have heard about happening a lot. I do think that we have a pretty good, solid team of ocular oncologists around the country who will fight for their patients, even if they come up against a Medicaid barrier where they say, oh yeah, insurance won't cover this. They're only going to cover enucleation, because they do have a lot of data and research showing that enucleation and brachytherapy are pretty equal in survivability rates, that in terms of, what is the long-term result of this? It is curative in the way that, the eye is no longer a problem. The problem is then the micrometastases, which probably seeded years and years before. So I was diagnosed in 2020. When they say micrometastases, they're saying, nah, your cancer probably didn't spread in 21 or 2022. That's just when it showed up on imaging. It probably spread as early as 2015, up to 5 years before your diagnosis was even found in your eye. So it's it's a crapshoot. It couldn't have been found because they didn't even know it existed in my eye to begin with. That's kind of where most of the research that we have now is leaning toward explaining metastases in that way, that it's likely it was seeded a long time beforehand. However, in terms of curing the eye, they can cure the eye. They can cure the eye. They can't necessarily say they can cure everything else, but if they can cure the eye and it's early enough in the diagnosis, then they do have a chance at curing the patient. And brachytherapy and enucleation have not been proven to be, it's not like if you remove the eye, a lot of people think, oh, well, if you remove the cancer, you're better off, right? It's not the case because of the micrometastases, because of the cancer likely seeding itself a long time before the eye is ever even diagnosed. Enucleation doesn't necessarily provide you with a cure-all. You're never going to deal with this again, even though the cancer's out of your eye and it's out of your face, right? It's no longer in your body, so you'd think it wouldn't be a problem, but that's just not how it works. So in terms of which one is better, doctors now can say, well, brachytherapy is better because not only does it provide the curative, cancer killing, the cancer no longer lives in your eye anymore, it's no longer active, and they can prove that and they can monitor that. It also provides an opportunity for some patients in the population, depending on the size of the tumor, to maintain their vision. And that's an important thing, because if you are dealing with enucleation, there is no vision. You completely lose all vision. You are now monocular. You have one living eye left. And so it is the kind of medical do no harm. That one is the one that does less harm. It still does harm, and it still can cause vision deterioration. And so we actually do have a really awesome clinical trial right now for small tumors that is specifically for really, really early caught tumors. And it has the ability to preserve vision while simultaneously treating the tumor. And that's a really powerful, it's called the COMPASS trial. And it's insanely awesome because it will mean that people who have a small tumor don't end up 20 years down the road with being okay with ocular melanoma, no metastatic disease, but now they've lost vision because over time,
Right.
radiation deteriorates the vision in your eye, no matter what. It's just a matter of how much damage is it going to do?
Mm.
And they have no way to equate and say exactly how much damage will happen due to whatever radiation you have. Doesn't matter if your tumor was big or small. There will be some level of radiation damage. So anyway, I just think that there's absolutely a lot of really good doctors out there who fight hard for their patients to not have to go through enucleation if it's not absolutely necessary. And that if it is coming up in insurance, I would say that those patients are probably not with a doctor who's fighting hard enough for them. And I hate to put it that way, but like that's kind of just where it is they're not with a doctor who is fighting hard enough for them. And that they may also be with a doctor who is operating kind of on a behind the scenes or behind the times kind of a way to treat ocular melanoma. And that if they are behind the times, please check out our resources, link up with the doctors and the physician guide that we have on our website on acureinsight.org. Please don't just get your eye enucleated if you have a tiny, tiny tumor. I mean, unless you absolutely want that to happen. Like there are so many other options available to you. And like I said, having the eye taken out does not equal you will never deal with this cancer again. That's just not how it works.
We'll link all of this in the show notes too, because I mean, you've referenced so many good resources. And, you also talked about two of the conversations that you had with the UCLA doctors who are actually at the forefront of this research. So we're going to link all that in the show notes so that people can easily go and learn more and continue their own education of these things. I know for me, Leah, I don't know, I know you have a very fluid understanding of melanoma. But for me in this conversation, I've literally learned so much that I've been over here taking 2 pages of notes to make sure that I'm not missing anything that I want to include with this episode. So thank you so much for coming on and for sharing all of your wisdom and insight. And we're going to link to your podcast so that people can continue their education and to learn more. And will you share one more time the website and the name of the podcast so listeners have that fresh in their brain as they are signing off of this and hopefully going over to your resources to learn more?
Yeah, of course. And thank you guys for having me on. So just for those of you guys listening, if you go to our YouTube channel and search A Cure in Sight, then you can find us on YouTube. And currently we stand at 700 YouTube subscribers. For anybody who knows how YouTube works, if you get to 1,000 people on your subscriber list, you actually can monetize YouTube. So if you feel like subscribing, even if you don't want to watch all of our content all of the time, even just being a subscriber and helping us get to that 1,000 will help us to monetize the channel. So we really could use the help there. We've done a lot of work this year to improve our production and to work with a really solid editing team. And so A Cure in Sight on YouTube. If you want to find our website, like we said, we'll link that in the show notes, and it's acureinsight.org. That's also the handle you can find us on social media is A Cure in Sight. And if you use any of the hashtags like I believe or ocular melanoma, you should find some of our content. But again, if you search for A Cure in Sight, that's where you're going to find the majority of our social media channels. Do you want me to share my personal social media? Like for anyone who wants to find me? Not that I'm going to tell you to go anywhere but A Cure in Sight.
If you want for listeners to connect with you as well, this is the perfect opportunity.
Anybody who wants to
share.
give me a follow on Instagram, it's just the.Danet.Peterson. And we'll link that in the show notes because nobody can spell my name right. If you can, I won't actually give you $1 million because I don't have $1 million, but like I can pretend. Nobody knows how to say my name. So if you're one of the few people who sees my name, Danet, spelled D-A-N-E-T, and actually says, oh yeah, that's Danet, you're rare. So you can find me on Facebook and on Instagram mostly. I do have a LinkedIn page that I use kind of just professionally. So if you're somebody maybe coming across this from the pharma companies or a doctor, you want to learn more, you want to interview on my podcast with A Cure in Sight, the I Believe podcast, then you're welcome to reach out to me there. I'm trying to think if there's anything else. Yeah, that's kind of the gist of it. I know we didn't like touch a whole ton on my personal story, but I really hope that we could just kind of keep the focus on just the general population of patients and all of that. If you guys do want to learn more about my personal story, please don't hesitate to reach out. I'm happy to send you to my personal podcast, which I guess we could also link. I have a podcast with my friend called the Resilient Joy podcast, and I have talked about my cancer story on there. It's just kind of constantly evolving, so it just it doesn't stay the same.
Yeah.
So like new things develop every week sometimes.
Yeah. Yeah, we'll link to that as well because there are certainly listeners who know that song and dance all too well. and they can absolutely relate to that, that everything changes kind of seemingly day to day, minute by minute,
Yeah.
hour by hour sometimes. But Danae, thank you so much for joining us. We so appreciate your take and sharing all of your wisdom. Like I said, I have pages of notes to review now. So I so appreciate your time, and
Got your homework cut out for
hopefully
you.
oh my gosh, absolutely. I am going to practice saying all of these different treatments like in my sleep over the next couple of days. But thank you so much.
Thank you,
Yeah. Thank
Danet.
you guys for having me.